Okay, good afternoon everybody, and thank you for inviting me to come and speak again on this topic of glaucoma in uveitis. Here we have, for this particular series, the whole series is about uveitis, and the glaucoma is just a small section, as opposed to some of the other talks where it's retina or it's a glaucoma module or something like that. So I'm Daniel Su. I am with the eye and retina surgeons, and I do the glaucoma for their group. I'm a glaucoma specialist, and I'm also a visiting consultant with the Singapore National Eye Centre with the glaucoma department, where I still return to see patients every week. I assume that they've already done lots of definitions and so on for uveitis, so I'm just going to do some simple definitions for glaucoma to ensure that we all understand, we all are thinking along the same lines for glaucoma. So the definition of glaucoma now is that it's a group of eye diseases where there's very characteristic optic nerve damage. The appearance of the nerve is very typical of what glaucoma is, and there would be corresponding visual field damage. The intraocular pressure may be elevated, but it's not absolutely essential for the diagnosis. And big groups of glaucoma which we often speak about are primary open-angle glaucoma, and that includes normal tension glaucoma. Some people do not like to differentiate high pressure POAG and NTG, so they all call that under open angle glaucoma. Then there's primary angle closure glaucoma and secondary glaucoma. Among secondary glaucoma, that can again be broken up into the open angle conditions as well as the closed angle conditions. And the open angle condition, pseudo-exfoliation is probably the most common, and then you have things like pigment dispersion, steroid-induced glaucoma, uveitic glaucoma, neovascular glaucoma, elevated episclerovenous pressure glaucoma, for example, Sturge-Weber, and then silicone oil glaucoma. And among the close-angle conditions, we have phacomorphic glaucoma, sublux lenses causing glaucoma. Neovascular disease can also be angle closure, just as uveitic can also be angle closure. And then you have eye syndrome. I'm very sure that you can find textbooks which give you even longer lists of secondary glaucomas, but we don't have to go through all of that. I'm sure you can find that. We're just here to get an introduction. Now, let's look at the intraocular pressure in patients who have uveitis. In patients with uveitis, the pressure is often normal, and it can even be low in those who have acute uveitis. By low, I mean possibly even single digits, without having a flat anterior chamber or something like that. I mean, we're talking about formed anterior chambers, but low intraocular pressure. And this kind of conditions is usually because of the cyclitis which occurs, meaning the ciliary body or essentially the structure which produces the aqueous in the eye, the epithelium of the ciliary, the whole ciliary process and things like that is actually inflamed. And as a result of that inflammation, there is reduced production of aqueous. There could also be greater outflow of aqueous through the uveoscleral outflow pathways. And that's because of more prostaglandins which are being secreted into the eye. And some of these prostaglandins which are being secreted as part of the inflammatory process actually help to improve your outflow. And that's also the mechanism by which many of the prostaglandins and the prostamides, meaning the whole tenoprost, travoprost, and tefloprost, and then you have imetoprost, which is not exactly a prostaglandin, but it's a prostamide. That's essentially how they are reducing eye pressure by promoting the outflow through the uveoscleral pathways. And as you remember, the production of aqueous takes place into the posterior chamber, and the aqueous will flow through the whole eye, and finally it comes around the front of the lens, the interior of the lens. It goes through the pupil into the anterior chamber, and it needs to exit the eye through the trabecular meshwork. And if for some reason there is any obstruction to that flow, to that pathway, then it's going to result in elevated intraocular pressure. So in both the open angle as well as the closed angle situation, glaucoma can occur. When the angles are open, it would usually be because there is some obstruction to the trabecular meshwork, either by fibrin, by inflammatory material, inflammatory cells. There could be trabeculitis, which means the actual trabecular meshwork is inflamed, and there could also be a steroid-induced mechanism, or simply the whole trabecular meshwork is being covered by a neovascular membrane. When there is angle closure, so you perform gonioscopy and you find that the angles are closed, there could be pupil block. So the aqueous is not really passing into the anterior chamber, it's all stuck in the posterior chamber. And in pupil block situation, the examination would reveal quite often an iris bombay. The pupil seems to be stuck down, or it looks like it's somehow obstructed, and the angles are closed. Or it might simply be that there's peripheral anterior synechium, and the anterior synechium could be formed because of the result of recurrent inflammation over quite a long time by the uveitic condition. And certainly some of the conditions can cause a forward displacement of the lens iris diaphragm. And that forward displacement of the lens iris diaphragm means that the entire lens iris diaphragm moves forward, and in the peripheral iris, you're actually closing up the trabecular meshwork. Now, in secondary open-angle glaucoma in uveitis, what is actually happening? So as I mentioned earlier, there is increased resistance to the outflow of aqueous through the trabecular meshwork, and this can occur because of mechanical obstruction of the meshwork by inflammatory cells, by protein, by fibrin. Any of these sitting in front of or sitting within the anterior chamber is going to simply make it more difficult for that aqueous to get out of the trabecular meshwork. The aqueous is often more proteinaceous as well. It's simply much thicker, it's much more viscous, it's not fluid, it's not like water. So it's going to have a lot of trouble traversing through the whole eye, getting through the pupil, getting out of the meshwork. And as I mentioned earlier, trabeculitis. Trabeculitis is actually swelling of the trabecular meshwork beams. Remember, all these in trabecular meshwork, we're not big open spaces, but it's actually, you would imagine like they are pillars, and all these pillars are now much wider, so that the space between the pillars are narrower, and you would think, well, how much space does it require for a molecule of water or something like that to pass through? But the fact remains that because of that increased thickening of the trabecular meshwork beams, the fluid in the aqueous just cannot pass through, and so everything gets blocked up. Or even if the water could pass through, it just traps all that inflammatory material, it traps the inflammatory cells, possibly blood and things like that. It just traps all that much more easily, resulting in the aqueous being having greater difficulty in passing through. In addition to that, Rho kinases, which are produced during the inflammatory processes, constrict the trabecular endothelium, and that would result in elevated intraocular pressure. And it's interesting to note that there is a new class of glaucoma eye drops which will gradually become available over the next few years, which are actually Rho kinase inhibitors, ROCK inhibitors, and that's what Rho kinase inhibitors seek to do, to reverse that constriction of the trabecular endothelium. As uveitis goes on and on and on, and we know that it's only the very fortunate few who get one episode and never again. Many of these uveitis patients actually would suffer the disease as recurrences, as flare-ups. It eventually leads to scarring and obliteration of the trabecular meshwork beams. And finally, it's really difficult, even though on gonioscopy it looks like it's open, but really the trabecular meshwork doesn't allow any of the aqueous to get through, or it allows much less than before. What about in steroid-induced glaucoma, which is another mechanism, which is different, which is independent of this? There's accumulation of glycosaminoglycans within the trabecular meshwork, and there's inhibited phagocytosis by the trabecular endothelial cells, and also inhibited synthesis of certain prostaglandins. And as a result, all this causes eye pressure to rise. Now, as uveitic patients are often also treated with steroid medications, whether it is topical steroids or injection steroids into the eye, or even systemic steroids. Both of these can add their effects to the whole clinical picture. Both of these can cause intraocular pressure to rise. It isn't such that they have to happen together or they happen in exclusion of one another. They can happen together, but what I'm trying to say is they happen independently of each other. And it may be very difficult to distinguish between the causes. So you have a patient who's got uveitis, he's got high eye pressure, but as you take a history, you know that he's also taking steroids. Which is the cause of the high pressure? Was it the uveitis first, or was it the steroids which came later? And that's one of the important things that we need to figure out if we want to be able to treat the glaucoma successfully, the elevated eye pressure successfully. So for secondary angle closure glaucoma, I divided it into three parts. One is pupil block, the next is PAS, peripheral anterior synechiae, or it could be anterior displacement of the lens iris diaphragm. So if it's pupil block, this patient could be suffering posterior synechiae. Again, very frequent if there's a lot of anterior chamber reaction, a lot of inflammation mainly in the anterior chamber. The patient who is usually phakic, after some time you might find that his pupil is very small and the pupil is really quite stuck down. And these patients, often you would examine them, you find that there's iris bombay, which means the iris is really very curved. The pupil is stuck down, the peripheral iris is very, very close to the cornea, and you would imagine that closes up the angles. There could be fibrin, there could be vitreous, there could be blood. Any of these could be obstructing the pupil, the passage of aqueous through the pupil into the anterior chamber. It could also be a sublux lens. Usually it would be it's not an IOL, it's going to be the phakic lens. So subluxation because of zonulysis means that the whole anterior lens surface is plastered against the pupil. So peripheral anterior synechiae can be a result of inflammation. It can also be a result of neovascular membrane. When the membrane first appears, angles are still open, eventually the membrane will contract, and eventually the whole meshwork will be obstructed. As for anterior displacement of the lens iris diaphragm, that in this situation of uveitis would occur if there was ciliary body swelling or uveal effusion, especially when it's very, very anterior. And when you examine the eye with a BIO or with an OCT for the posterior retina, it may not be so apparent, but it's peripheral uveal effusion. Sometimes you would require a UBM in order to be able to tell this. Just a simple B scan would be inadequate. It really requires ultrasound biomicroscopy to look at the anterior part of the uvea and the ciliary body, to look at its configuration and things like that, to see that the ciliary body is rotated forwards. And remember, when you look at these scans, you're just seeing one slice. So you see on two sides, you might see the ciliary body, but you have to remember that it's a whole ring. It's a whole ring behind the iris, and so as it rotates forward, it may not be uniformly anteriorly rotated, but that anterior pushing all around is going to cause the whole iris to move forwards and eventually to close it up. And this can happen in VKH as well as posterior scleritis. All of these are going to prevent the aqueous from reaching the trabecular meshwork, so there's no drainage. Now, one of the things which we need to be clear about in glaucoma is that certain terms which apply to primary high pressure situations like ocular hypertension, like POAG, are very different from when you have high pressure in a secondary glaucoma condition. So when you have a secondary cause for high eye pressure, like uveitis, like neovascular glaucoma, like steroid-induced glaucoma, like sublux lens kind of thing, if the pressure is high, it must be addressed. This is quite different from ocular hypertension. Ocular hypertension has to be defined where it is high eye pressure, the nerve appears normal, all the other investigations are normal, and there is no secondary cause for high eye pressure, like all those things which we mentioned earlier. So if you have a patient who has uveitis or is on steroids and the IOP is high, that must be addressed, that must be dealt with. You cannot leave it alone and say that, don't worry, it'll be fine, because ocular hypertension treatment study says that after 5 years, only 9.9% of them became glaucoma. And when it was left untreated, 9.9%. If we treated them, it was 5.5%, so big deal. But they weren't looking at uveitic conditions. They were looking at patients who had just plain simple high eye pressure. There was no secondary cause. So let's be very clear, all right? If there is uveitis, if there is a secondary cause for the high eye pressure, you have to deal with it to prevent glaucomatous nerve damage. If you don't, the damage will come. That will happen. It is as sure as death, if you want to put it that way. All right? So let's look at some studies which tell us how common this glaucoma in uveitis is. And here we have 3 different studies from different parts of the world. One is taken from North California, one is from Japan, and one is from UK. Obviously, in each of these different studies, you have a different profile of patient demographics, both by race and so on, as well as a different type of uveitic conditions which appear. And if you go through the papers, you'll probably discover more about the differences in age groups and so on and so forth. So in North California, they found that just over 10% of the patients with uveitis develop glaucoma. What were the mechanisms involved? Just over a third were uveitis alone, 16% were steroid-induced, and almost half of them were actually a combination of these, combined mechanisms, that's what it means. And out of all these, 15% of uveitis patients with elevated IOP required treatment. So while 10% develop glaucoma, 15%, that means an even higher percentage, they don't have glaucoma, but the pressure is high and it needs treatment. Okay? It may not need treatment forever. They may not have eventually developed the nerve damage which is typical of glaucoma, but it needed to be addressed. It may have been short term, but it had to be addressed. In Japan, it was 18.3% of uveitis which developed glaucoma, and in the UK, it was just under 10%. However, nearly 1/3 of the uveitis with raised intraocular pressure needed treatment. So don't wait for the nerve to become damaged before you treat. You've already lost something. The patient has already lost something, and it's irreversible. Let's not wait till problems occur. Don't make them earn their glaucoma treatment by proving to you that the nerve damage has already set in. We want to prevent the nerve damage. They've got enough problems as it is. So what are some of the risk factors for elevated intraocular pressure? Number 1, active inflammation. No surprise, right? Because we spoke about that so much. That active inflammation can cause obstruction of the trabecular meshwork, damage to the trabecular meshwork, so that can result in elevated IOP. The next is steroid usage, especially if they're intraocular steroid implants, because these are fairly high dose and they are very prolonged drug release, so there's a lot of steroid which gets in, and sometimes it is possibly an overkill. And have a look there, it was 4 to 5% increased risk when there was steroid usage. Other risk factors are older patients, longer duration of uveitis, and the fact is that we have both acute uveitis as well as chronic uveitis having the possibility of getting a high eye pressure, but it is more than double the chronic uveitis who would end up with high IOP requiring treatment. And as as many of you would probably have experienced already, those with viral anterior uveitis are much more likely to get elevated IOP. VKH patients, probably by the fact that they are very long chronic disease, they would have active inflammation, although sometimes it doesn't look so obvious, and many of them need steroids. They end up having elevated IOP. So now let's look at anterior uveitis alone. What are elevated IOP in anterior uveitis? This is associated with Kochner-Schlossman, which many people believe is either HSV or CMV or both of them contributing. Fuchs heterochromic cyclitis, where these are some of the implicated causes. Those anterior uveitis which are viral, belonging to the HSV and VZV and even the CMV. And you can see that many of these, really a high proportion of these would end up with high IOP. And those of you who have looked at after such patients, the IOP can be very high. It's not just a little bit high. It's not like 23 or 25 millimeters mercury. If you get a patient with that, you are really lucky, and the patient is really lucky. We're thinking like pressures in the 50s even. And when they get, with all the eye drops on board, sometimes it goes to 30 and you think, oh, there's nothing left to give, right? So CMV, acute uveitis, many of them have IOP more than 50 and 8% develop glaucomatous optic neuropathy. This is the typical, when we say glaucomatous optic neuropathy, we're referring to disc appearance which is typical of glaucoma damage. Among the chronic uveitis, that means it's not acute episode. Chronic uveitis, the IOP may not reach so high, but more than a third of them have glaucomatous optic neuropathy. So if you don't deal with it, each time it happens, or each time you see the eye pressure being high, you can be sure that they're going to end up with nerve damage. So we, as recommended by the paper, many of us would tap the anterior chamber, draw aqueous for tetraplex PCR testing, especially when there's recurrent episodes. Perhaps if it's the first time you're meeting the patient, the first episode, you might say, okay, hang on, we'll let it go first. We'll just treat it like there is nothing else we need to do other than trying to control inflammation and eye pressure. But after it comes back, especially with several rounds, you should do an AC tap, and you should start on antivirals to prevent recurrence and control the IOP. So here's a case that I was looking after. She was referred to me several years after she had all these recurrent attacks. And when she came to me, she was 54 years old. She works in a church, and she had this unusual leg surgery as a child, which subsequently somehow ended up with a chronic infection. Maybe there was a chronic osteomyelitis, I'm not very clear, but she is still followed up till today by an ID physician related to this issue. In the year 2000, she underwent phaco in both eyes, and sometime later, she developed POAG, what seems to be POAG, and that was well controlled with both Xalatan and Timolol. And then the right eye, I was told, had recurrent anterior uveitis for 10 years. Each round was just treated with Tobradex, tobramycin with dexamethasone, and Timolol and Trusol, or something like that. And if the eye pressure got a bit high, they'll give her tablets for Diamox for a few days, and then the pressure will come down. And she would actually develop 3 to 4 attacks a year, and the highest eye pressure recorded was 44. Each time the attack comes, it's usually, the pressure is usually more than 30, but the highest recorded is 44, and in between the attacks, the IOP was somewhere in the low teens. No investigations had been done, occasional visual field over the last 10 years. So this is what she looked like, and from wherever you are, you will probably be able to see that the right eye optic nerve has got a lot thinner rims, especially in the superior and the inferior. The left eye, the picture seems to be a little bit more hazy, but you can see the disc is a lot more pink and the rims are thicker. They're not fantastic either. They have an increased CD ratio, but they are definitely better than the right side. So in early 2015, there was anterior uveitis on the right eye, just plus cells, small KPs, and the IOP was 26. And this is what she was like. This is the first time I'm seeing her. We do the OCT, right eye is here, left eye is here, and you can see that the RNFL on the right side is really very thin. Okay, that reads 54, and that is probably something really low as well. On the other side, the left side, although the nerve doesn't look too great, but the OCT shows that it's still fairly healthy RNFL, and that reads 116 down there. When you look at the visual fields, this is right eye. I assume you all know that. Right eye, and this is left eye, and you can see very dense superior visual field defect, and it comes down onto the nasal side inferiorly as well. The MD reads as minus 14.9. The VFI, visual field index, reads as 60 on the right side. On this left side, we have a fairly normal looking visual field, maybe a little bit of nasal issue there. But this actually is 99% on the VFI and is minus 2.0 on the MD. Anybody will be able to tell you that the right eye is having trouble. The visual field is advanced. There is the appearance of the nerve shows that it's advanced optic nerve cupping, and the pressure is now 26. So she had, she disappeared for a few months. After we started her on treatment, she didn't come back. And then she comes back again in August with a recurrence. And this time I tell her, you know, it's been coming like this for how many, for really so many years. And this year alone, you've had at least 2 before you're referred to me. I think we really need to get down to what the cause is. So we did an AC tap, we sent it for tetraplex PCR, and it comes back CNV positive. So I started her on Vergan gel in addition to the glaucoma medications. There was a mild response, meaning that the anterior chamber inflammation reduced a little bit, but not a lot. And the eye pressure likewise did not come back down to normal. It maybe went down to the low 20s, 22, 23, which is really not good enough for this amount of nerve damage. So I said, you know, I think we need to go further. We really need systemic valganciclovir as well. So she said, okay, I'll go and see my own ID physician. So she went to see her ID physician who gave her Valsite. The inflammation improved, the IOP went down to normal, though she still needed the glaucoma medications. However, 1 month later, she was admitted to the Singapore General Hospital with pancytopenia. And she had to go there because her ID physician, who's in private practice, was overseas, so she couldn't get to see that person. So she was admitted to the hospital, and after they went through the drug history and they examined her and so on, they decided that it was the Valsite which caused the pancytopenia, and they said she had to stop that. So because I was still seeing patients, I still do see. So they referred her to see me at the Singapore National Eye Centre as well, and I got the uveitis team at the Singapore National Eye Centre to help, and they said, well, we've got Vergan gel, we can't use Valsite, we'll try the valganciclovir eye drops, which they were just trying out, and I think they were going to use it every hour. So that helped to control the inflammation, but the IOP was still low 20s because we couldn't fully control the whole inflammation from the CNV. The AC seemed to be a bit quiet. Anyway, we did a trabeculectomy with mitomycin C for her. She's already pseudophakic, so we just did a trabeculectomy with mitomycin C. And by February 2017, the eye is quiet. She does not require any steroid medications. There's no glaucoma medications, just Vergan gel. No systemic medications. The other eye is still just using Zaratan and Timolol to control her eye pressure. I see her every few months at the Singapore National Eye Centre, but essentially she's now stable. So this is how she has essentially got worse, because she probably wasn't optimally worked up in the earlier years. So how do we exactly evaluate a patient? A uveitis patient that we think has got glaucoma or is obviously glaucoma, but you know, you're trying to get control, you're trying to get on top of things rather than being reactionary. Every time the pressure goes up, you add one more drop. When the pressure goes down, you take it away, or you add two more drops and you try taking it, you're just doing this. Well, we need to determine the type of uveitis because obviously certain types of uveitis are more likely to cause problems because if it was anterior uveitis, if it was a viral anterior uveitis, you know it's going to have certain kinds of characteristics. The pressure is going to be high each time. It may be normal in between, but it will be high each time it comes. We want to know what the current inflammatory status is. Is the IOP high now when the eye is actively inflamed or when the eye is quiet? That gives you a better idea as to what's the cause of the high IOP. What's the mechanism of glaucoma? Is it uveitis, inflammation, or is it steroids, or is it neovascular membrane, or something like that? How bad is the glaucoma? Then you know how hard you need to hit. And is there progression of disease? Ever since the patient has got the diagnosis, is the nerve looking worse? Is the visual field getting worse? What are the current medications? What's the IOP like while the patient is using these medications? What has been used in the past? Did it work? Was there allergy? Was there intolerance? Or there was simply no effect at all? You want to know all this so that you can make the right decisions. And then you, of course, need to examine the patient really well. Needless to say, you examine the slit lamp to figure out what the inflammatory status is. The gonioscopy is so that you know if it's open or closed angles. And that has a bearing on whether you need to overcome pupil block or something like that. You want to know if there's a RAPD. If the RAPD is because of something in the retina, or is it because the nerve is just in such a bad state? That gives you an idea of how hard you need to try. So obviously you need to examine the optic nerve. Now, for glaucoma, as a glaucoma doctor, I also believe that it's important to do a dilated retinal examination. Not because I want to give intravitreal anti-VEGF injections to steal business from my medical retina colleagues. I think glaucoma doctors are busy enough. But because there are times where a visual field defect is not because of an optic nerve disease, but maybe it's got a scar on the retina from their previous retinitis or choroiditis or something like that. Now, just to give an examination, an example. While I was still at the National Eye Center, I had a referral from a medical retina and surgical retina fellow. And he says, "Dear Dr. Su, the nerve is pale and the visual field is constricted. Please see and treat." And so the patient came and I took a look at the nerve through the undilated pupil and I said, "Wait a minute, so close to the nerve and I already see all these bone spicules. Let's dilate and let's have a look a little bit more closely. This looks a bit strange." And it turned out to be retinitis pigmentosa. So I called the fellow back and I said, "I think you need to look after this patient. I'm not sure you need to do anything for him because there's probably nothing left to do, but the pressure is normal." So the dilated fundal examination is to help you understand whether the visual field defects are really all optic nerve issues or it's actually a retinal issue as well. Okay? So investigations, the ASOCT may be helpful. The UBM sometimes is helpful. We don't have to do a lot of UBMs, and it's not always easy to order and obtain UBMs because that the pool of good UBM technicians is small. We're fortunate that at the eye center we have some who are very good, but it's not so easy. These photos are good for recording, OCT of the RNFL and macular, and of course you need to get visual fields done at appropriate times. So let's just have a look at some pictures as how we evaluate some of these patients. If you look at this pair of optic disc photos, this same patient, both eyes of the same patient, what would you say is an abnormality, obvious abnormality? Just shout out. Is this abnormal?
He's got this ratio. Temporal rims on the right eye slightly thin. So there's peripapillary atrophy as well.
Okay, so we have high CD ratio.
Yep.
We have peripapillary atrophy. This is tilted. Okay, tilted discs are quite common. So that one I don't consider a glaucomatous abnormality, but yes, both of them are tilted. That's for sure. Anything else?
The left eye, maybe some RNFL accurate feeling over there. I don't know that.
This one here?
Yeah.
So that's a RNFL defect. Okay?
Yeah.
RNFL defect. Anything else? So you see one RNFL defect here. Do you see any here? Yes?
Oh, that wedge over there.
Yes. There's actually one wedge here, fairly broad, and another wedge here, fairly broad. This one is a slender wedge. Okay? So just from these two disc photos, you already see that there's something not quite right. The lighting here is not so good, but there's actually another funny wedge down there. But if you had a look at this on the red free, you can see that this is very distinct. You can trace it up to here, all the way to the horizontal roughly. RNFL defect there. These are two broader RNFL defects. Okay, so just by looking at this, you can start predicting what the OCT is going to look like, what the visual field is going to look like, right? So it's really useful to examine the nerve with the pupils dilated. And even if you are evaluating patients for glaucoma, I really think it is useful. It's not just for evaluating retina, but for evaluating glaucoma as well. It helps you get a better quality view, especially if there's cataract. And if you want to take photographs, it will give you a better view. If you want to do OCT of the nerve, it is definitely, I think it's better, although of course Zeiss will tell you, you don't have to dilate the pupils to do your serous scans. Yeah, sure, you don't have to, but I think you're going to get better quality pictures. So this is what the OCT of that same patient looks like. In the right eye, there is loss of RNFL superiorly and inferiorly. This other side, it seems to be quite normal, but remember that inferior there was a problem down there, and you're actually just crossing yellow into red, but it doesn't show up so obviously down here. And when we do this is for those of you who are not so familiar, it's the ganglion cell analysis. So you do the 512 by 128 macular scan, and from there the software actually looks at ganglion cell thickness and so on, and where it shows up as red, that's where it's actually measured as being thinner than normal. Where it shows up as green is of course normal, yellow is suspicious. So you see that the right eye, the whole ganglion cell complex area in this macula is very thin. On the left side, it is thin inferiorly, which would match where we saw the retinal nerve fiber layer defect. Okay, so this helps you to confirm what you saw clinically, but it does not remove the need to examine the nerve yourself. And this is what the visual field looks like. Left eye and right eye. Right eye was the one with much more severe RNFL as well as ganglion cell loss. The left eye, you see that there's structural abnormality, but functionally the patient is still normal. So we know that the patient can lose up to, different studies will show you different amounts, but maybe 30% of the nerve can be damaged before you see abnormalities on the visual field test. Okay, so this is just an example of how we examine critically as we're trying to evaluate what's happening for glaucoma. I've not told you anything about the history of that patient. I haven't told you anything about what the anterior chamber looks like, or the lens status, the inflammatory status, the IOP. I don't care what the IOP is. Even if the IOP was 12, I think this tells you that there is glaucoma, right? Even if the IOP was 30, this is glaucoma. We make the decision independent of the IOP, at least to decide on the diagnostic label. Now, please be careful about relying on scans to come to a diagnosis, because RNFL thickness measurements or macular thickness measurements can be confounded by uveitis. As we all know, in uveitis, the retina, whether it's the around the disc swelling, macular swelling, retina swelling, whatever it is, that can happen when the patients are actively inflamed. And sometimes the anterior chamber may look very quiet, there's no cells floating around in the vitreous, but still there can be swelling. Not always perceptible when you do a biomicroscopy, but there could be. And as a result, there could be a greater than expected RNFL thickness when you're doing the OCT scans for these patients with uveitis, and you're trying to evaluate their retina. Then you discover, wow, this patient, I thought, I had anticipated that the RNFL would be really severely damaged, but you know, here I do the scan, it looks really good. It looks really good. Well, what can actually happen is that these uveitic glaucoma eyes appear to have normal RNFL measurements. They're all green, or maybe they exceed green even, during the time of active inflammation and raised IOP. Then subsequently, when the inflammation gets much better, several months later, and the IOP is better, and then you rescan them, and you find that, whoa, the RNFL is really thinned out a lot, and the nerve now looks more cupped. What's actually happening is that they're returning to their baseline. When you scan them, they were in this inflamed and swollen state. So everything was abnormally thickened. But now they're returning to their normal state. So here are some papers. There's this one and then the next one as well. If you look at the first column here, this is active uveitis. Second column is inactive uveitis. Overall global RNFL for the active uveitis was 140. And then inactive uveitis, they actually fell to 107. And in each of the different quadrants, you can actually see it's much, much less. And down below here in the next table, again, this is active uveitis, first column. Second column is inactive uveitis, and these are different studies which show non-uveitic glaucoma. So you see active is 95, inactive uveitis 92, and non-uveitic glaucoma is in the 60s or 50s, depending on which column you look at. So whatever reading you get, just bear all these things in mind. Don't get too carried away by just, oh, it's all green, it's great. Oh no, it's all red, it's bad. It isn't so straightforward. You need to think a little bit about this. And here they're trying to show you this gray line here is active uveitis. All right. The blue line is inactive uveitis, and the orange one is glaucoma not in uveitis patients. So this top gray line was the thickness when the patients have active swelling and inflammation. You see that the thickness of the RNFL is way beyond green, much, much thicker than green. Whereas when they came down to a non-inflamed state, they came into the green state, and actually, if they were truly glaucoma like a non-uveitic glaucoma, they would be even less thick. So you've got to be careful with that. Okay? This other scan, this actually shows a series of scans of the same eye, A, B, C, D, E. This first scan was taken when the patient had, when the patient was quiet, there was no inflammation at that point of time. The next one, B, when there was a flare-up, and you can see that there are all these green lines, all these green shadings there. These are follow-up scans, meaning that they register exactly the same spot so that subsequent scans follow on the same spot. You see that it's actually got thicker. Where it's got thicker, it shows green, and then here it begins to resolve a little bit, so you see a little bit of red, but some areas are still green, some areas are still increasing in its thickness, some areas are falling in their thickness, and for scan D and scan E, it is actually getting less and less inflamed, less and less thickened. You actually see all this red appearing. Under normal circumstances, when you see so much red appearing in an RNFL scan, it means the patient is progressing. But this was actually going from quiet to inflamed, and then gradually getting under control again. This is how much the RNFL can change within a period of time. All right, and the dates given down here are November 2010, October 2011, November 2011, January 2012, May 2012. So this is only about a 1.5 year span, and you could see that fluctuation going from normal to thick to less thick. So just be careful of that.
Okay, so
yes?
Now, in your experience, is this phenomenon observed in patients with, say, chronic anterior uveitis only with no significant posterior involvement?
Well, that's a tricky one to ask, because we don't usually do such frequent scanning for our patients. Yeah. Okay, so the question was, if it was a patient with just chronic anterior uveitis and a posterior segment looked entirely quiet, would we see the same phenomenon as well? I would say it may happen. I do not know for sure, because we don't do such frequent scans of the RNFL for our patients. If the IOP is okay, meaning it's adequately controlled, I don't do routine surveillance RNFL, unless maybe it's once a year or once in 2 years or something like that. Asrani is at Duke in the US, the Duke Eye Center in the US, and anyway, because the insurance pays for all the scans and things like that, they tend to be a little bit more generous with how frequently they scan their patients. So now, when we come to treatment of glaucoma in uveitis, I think there are 3 essential principles, which if you remember nothing else, please remember this. Number 1, you've got to get the inflammation under control. Get the uveitic inflammation under control. Deal with underlying causes, if there are any. And then you must reduce the IOP. When you do these things together, you're going to get good control of your uveitis, which will also help you with your control of your glaucoma and prevent optic nerve damage. So control the inflammation, topical, use oral or parenterals, if necessary, steroids, NSAIDs, immunosuppressants. I'll leave it to the other speakers to teach you and to explain to you all these things. Treating infections or underlying causes, meaning we have to search for them. You have to search, identify it, deal with it, and finally reduce the IOP using eye drops or dealing with steroid response if you can, and things like that. So the treatment of the glaucoma, we can use eye drops, we can use oral acetazolamide, and we often may have to add on cycloplegic agents. They help to relieve the ciliary spasm so that there's less pain in the eye. They also help to stabilize the blood ocular barrier. So things like atropine eye drops, they're helpful to the patients as well. Laser iridotomies may be needed for those with angle closure, for those with pupil block especially. You'll see that once the iridotomy is patent, there is immediate relief of the iris Bombay configuration. We can do lasers by transscleral cyclodestruction. Generally, SLT is not so, doesn't have good proof. We'll come to that. Surgery, there's trabeculectomy, there's drainage tube, and I suppose people are considering MIGS now. So treat IOP aggressively. If the IOP is high, you've got to get it down to normal. Recurrent episodes of elevated IOP or persistently high IOP will result in optic nerve damage. What do I mean by the first part? Remember the example of the 54-year-old lady with CMV that I did the AC tap for. She had multiple episodes of high eye pressure reaching the 40s. In between, she's always in the teens. Without treatment, she's in the teens. But yet we saw how severe the optic nerve damage was and the visual field defect and so on. So that can happen, okay? It doesn't mean that just because the IOP comes down to the teens without treatment, therefore each episode you can say, oh, don't worry, we'll just give you timolol and 5 tablets of Diamox to take home with you, and that's going to be enough. It is not enough, all right? Needless to say, if the IOP is high continuously, that has to be dealt with. So glaucoma is a major cause of blindness in uveitis, and up to 10 to 12% of the blindness in uveitis is actually caused by glaucoma. So this is not a problem to be ignored. Medications, I believe for the eye drops, you can use all classes as long as there are no contraindications from systemic conditions like asthma, like bradycardia. Children should not have alpha agonists like alpha-GAN because that is CNS depressant. I believe there's no contraindications to the use of prostaglandin eye drops, though I know that there are some other glaucoma doctors who avoid using prostaglandins in uveitic patients. I will only say that if it is obvious the patient's cystoid macular edema is worsen, is exacerbated by the prostaglandins, you may need to stop it. It is possible that that happens. If the patients have posterior synechia, you should use cycloplegics. That helps to dilate the pupil and break the posterior synechia as well. Is there steroid response? If you think there is steroid response, then you try to taper the steroids to the minimum level that the patient can have, but still keep the inflammation under control. But it's not always easy to do that. It's not always easy to do that. And you should not hold back treating with all classes of eye drops plus Dymox if needed, assuming that their kidney function is good enough and so on and so forth. So as I mentioned earlier, laser iridotomy is required if pupil block is present. Inflammation may cause the PI to close again, so you may need to do multiple, more than one, meaning more than once. I think multiple small PIs are not useful. If they're going to close, they can all close all at the same time. You may need to make a slightly larger one. Some people think a surgical PI is better. Yes, certainly is better, but then that is a surgery. And steroids do prevent closure. I think there's very weak evidence for SLT to be used in uveitic glaucoma. Certainly, one of the mechanisms by which SLT is believed to act is by kicking off a friendly inflammation in the eye in order to clear up the inflammatory debris and so on, the microscopic debris which obstructs the TM. TCP, transscleral cyclophotocoagulation, is generally used for poor prognosis eyes, meaning the eye is very poor vision, maybe hand movements, PL or NPL, and you're really bringing down the eye pressure to prevent pain, a painful blind eye. And in the past, we used to reserve it for those who are on maximum medical therapy and yet the pressure is high. There is always a risk of hypotony and phthisis, so we tell the patient you might lose all vision entirely. It is possible. But now, with the advent of micropulse TCP, this is a much milder laser application, so there is less destruction of ciliary cells in the ciliary processes, so there's less inflammation post-surgery, but there is also less IOP reduction. You can get fairly decent IOP reduction, but it is not going to be as dramatic. But the nice thing is that the inflammation is less and it doesn't last so long. So TCP, the inflammation can last more than 3 months. You're still on Bradford, of course tapered dose of Bradford. You might still be on atropine to try, and you're still seeing cells floating around. There's still mild flare. But micropulse TCP, within, I would say, a week or 2 weeks, the eye is much, much quieter. So the makers or the people who invented micropulse TCP says it can be repeated, and I have repeated it. There's much less risk or virtually no risk of hypotony or phthisis with micropulse TCP. Surgery, up to 30% of eyes with uveitic glaucoma need surgery. And we have to remember that we cannot take POAG success, reported success rate for POAG as being the success rate for uveitic glaucoma. Because of the inflammation which occurs, and they can still have recurrent inflammation after the surgery, that is an enemy of glaucoma surgery. That inflammation and that subsequent scarring can easily cause the trabeculectomy to fail. So they're not going to be as likely to succeed without eye drops as POAG. And it's difficult to be sure when exactly is a good time to intervene, because many of these patients are going to be high pressure while they're actively inflamed. And you may be pushed to have to do that surgery during that period of inflammation. Ideally, you don't want to. Ideally, you want the eye to be quiet for minimum 3 months and so on, but you don't always have that time. But I would say that you try to hold off the surgery till there's definite evidence of progression, because you might do the surgery when the eye is actively inflamed, and then when the inflammation is reduced, then the eye goes into hypotony because there is less aqueous obstruction, and now you have this big sclerostomy which is letting all the aqueous out of the eye. You could end up with hypotony, which is really troublesome. So we could do a trabeculectomy with mitomycin C. I would not advise trabeculectomy without anti-metabolite for anybody, much less for uveitis, because it's just going to fail very quickly, within weeks possibly. Remember, there's a possibility of hypotony, so that has to be discussed with the patient, and subsequent flare-ups of uveitis may cause failure. Even if you try to do blend needlings with 5-FU and so on, it just may not work. It may not be revived anymore. You will probably have to just give up on that site, and if you really need to do surgery, go to another site. You can certainly do glaucoma drainage implants. I would say the valve implants have an advantage because you can try to mitigate the possibility of hypotony, but certainly again with these, recurrent inflammation can cause failure there because there will just be more scarring surrounding the plate. And here's a study which compared trabeculectomy with mitomycin C against glaucoma drainage implants. And this is the curve. The dark curve, the dark line is the trabeculectomy. The dotted line is the glaucoma drainage implant. And this is comparing over 24 months. Here it looks, after the first week, it looks like the trabeculectomy is much, much better because this is where hypertensive phase occurs, typical normal hypertensive phase, which we see in tube implants. But after that, really after 24 months, they're almost at the same endpoint. And you can see that the qualified success in trabeculectomy after 24 months is 74 plus minus 6%. In the glaucoma drainage implant, it's 69 plus minus 11%. And the p-value is not very significant. In fact, it never reached significance in whatever they evaluated in here. So I think it just reflects the fact that the nature of disease means that either surgery is not going to achieve fantastic results, but it may need to be done during that time. Okay, so I'm going to close with a final case report. This was a 57-year-old male who had a right eye cataract surgery in 2009. After surgery, he had very good vision, 6.6 and 5 in both eyes. 2010 November, he developed right eye panuveitis. His vision dropped a little bit in the right eye, and he was being worked up for endogenous endophthalmitis, but subsequently he defaulted. Then a few months later, he came back, March 2011. The right eye was hand movements vision, the left eye was count fingers. In both eyes, there was lots of anterior inflammation, vitritis, retinitis. His pressure at that time was 4 in the right and 12 in the left. But the cut-disc ratio was still quite normal. You can see that through the haze and all these spots. So he subsequently developed scleritis, and he was being treated by the uveitis team who was looking after him with oral ciprofloxacin, oral prednisolone, and several months later they diagnosed this as being Behçet's disease. So by that time his vision is hand movements and 615, right eye pressure is 43, left eye is 13, his CD ratio is 0.9, it's pale, the left eye is 0.4, and he's on all of these medications. He was referred to me and we added all this stuff to try and get the pressure under control. A few months later, his pressure is now in the teens without Diamox. At least we got him off Diamox, and at least his pressure is a bit better. And he had, I would just say, satisfactory, in inverted commas, IOP control from 2012 to 2015 on eye drops only. That means no Diamox required, but many recurrent episodes of inflammation. Unfortunately, he's not a very compliant patient in terms of eye drops as well as follow-ups. So he'd come up for visits, a few rounds, and then he'll disappear for extended period, and then he'll come back when he feels his vision is not so great, and then he'll disappear for, so that's how he is. June 2015, his vision is like that, and the IOP on the left eye is not good, on the right eye is, so to speak, satisfactory. A few months later, vision is about the same, or it's deteriorating even at the left, and the IOP. So all the time the IOP is low 20s, high teens through this whole time. And finally, we have him on maximum eye drops. He's on Diamox 4 times a day, and he tells me he's almost incontinent. He's a second-hand car salesman, and he finds that he just can't get to the toilet quickly enough much of the time. So this is really hampering his work and his life. So finally, he had a left arm tube done in September 2016. He went through a hypertensive phase, and then even after the surgery, he's not very consistent with his post-op eye drops, with his glaucoma eye drops, which we usually keep on for some time. because it does help to prevent very severe hypertensive phase just by decreasing aqueous production. That can help to reduce the thickening of the fibrotic capsule around the plate, and we had him on oral dialogues. So finally, after lots of struggles, we got him to, by September 2016, by May 2017, this is how his vision is. The right eye is really very poor, right eye pressure is 24, FI is 14, and we have him on these eye drops. So it's 4 eye drops in the right, 3 eye drops in the left, no dialogues. And he still comes intermittently for visits and not. I just saw him 3 weeks ago. His vision in both eyes is worse, though his pressure is good enough. He's still trying to work, but he can barely fill up the paperwork every time he wants to sell a car. So it's really very difficult for him. And well, this is how our patients may end up if there is inadequate treatment. So in summary, I just want to emphasize that for glaucoma, for uveitis patients with glaucoma, you need to identify and treat the mechanism of the glaucoma or the high eye pressure while you're treating the uveitis. Remember that glaucoma can cause blindness. It is an important cause of blindness in uveitis patients, and you've got to treat the high IOP aggressively. Okay, let's have questions.
Any questions from the floor? Yes,
in case of steroid responders, do you prefer dexamethasone over prednisone? Is it having any advantage?
I take that to mean that if you are trying to cut down the steroids in order to help reduce steroid-induced high pressure, is that what you mean? Okay.
Like to replace, suppose patient is on prednisone, so we replace it with dexamethasone. Will it have the anti-inflammatory effect of steroid, and simultaneously it will be having low increased IOP, like the IOP increase will be less?
It may have a little bit of difference because Predfort is the strongest eye drop form of steroid. Dexamethasone is a little bit weaker, but I will tell you that every steroid preparation can cause elevated IOP. So even Lotimax can cause elevated IOP, even though when it was first created, it was said that, oh, there'll be hardly any high IOP and so on and so forth. So let's just say a patient is on Predfort and the pressure is high. If you really can cut down, there are 2 ways to do it. You can either cut down the frequency of the Predfort, or you can switch to a different steroid preparation. But bearing in mind that you actually want to keep the inflammation under control. So it's not always possible to stop or switch. Sometimes you just have to continue with the same Predfort at that level, because you know that if you cut it down, the inflammation is going to come back and so on and so forth. So sometimes you end up having to hold the steroids there, and then you add your glaucoma medications to that.
Second question is, sometimes inflammatory dilated iris vessels will be there, and practically sometimes it's difficult to differentiate from NVI, neovascular iris. Any particular clues to differentiate those?
Well, I think one way is to look into the angles, to do a gonioscopy and look carefully at the trabecular meshwork. If you see the iris vessels within the iris, that means not in a pupil. If you don't see any vessels in the trabecular meshwork at all, it's unlikely to be neovascular glaucoma. Because if it was such prominent iris vessels, you should see a fairly distinct network within the all the 4 quadrants. It wouldn't be so invisible that you can't see them, unless there's PAS everywhere, and you know that there is ischemia and that sort of thing. You look in the retina and it looks like a post-CRVO or proliferative diabetic retinopathy, that kind of retinal look. Then you're going to say, yeah, this is more likely a neovascular glaucoma situation. So you draw the clues from everywhere else in the examination as well. Yes.
Yeah, whenever I attend meeting, I like to find out new treatments. So So I'm just wondering about the eye drops, the non-gangliosidoid eye drop. What's your experience with it treating CMV and uveitis?
Okay, I will tell you that I have hardly any experience because it was the uveitis team at SNEC which was preparing it in their pharmacy and giving it to this patient that I mentioned it. But since I continued to look after her while I was at SNEC, so I saw her here at Camden first, and then subsequently she was transferred to SGH for the pancytopenic period. It seemed to get the eye under control better than just Vergengel alone, but it was not as good as Vergengel plus Vancite.
Is it a higher concentration?
Yeah, that's right.
It takes very long too. If you have no oral and you have CMV TAP positive proven and high titers, it takes very long, and you really have to sort of hold your breath every time and wait. The patient's adamant, I don't want treatment, I don't want to, refuse, don't care, I don't care, I don't like. This is the best you can do for them. But I have patients who are stabilized on it, but it takes months. And you know, they've got all the KPs so horrible because they've got endothelitis, IOP is damn high, but after that it's very slow.
Yes.
I just personally feel that for uveitic glaucoma, sometimes when you're really stuck, use steroid not getting better, Vitamix doesn't work. All the options of anti-glaucoma medicine have been given.
Yes.
Been on dying knobs for the longest time. I found it sometimes actually doing surgery is the best option at the
True.
end of the day.
Yeah.
I'm just not sure whether it's at the same.
Yeah, so there have been a few patients that I have exactly the same situation. Then when the surgery is done, everything just seems to quieten down. It's almost like you open up a hole where all the virus or the whatever it is could get out of the intraocular space. So it went into the conjunctival space, and then there would be this period of time where they have a honeymoon, you know, maybe no medicine, no glaucoma medicines, and then they're tapering on their steroids and so on, the post-op steroids, and everything is good. And then after either 1.5 years or 2 years or whatever it is, maybe there's another attack and then things start to rise again. But you have one possibly scarred black down there, which means one surgical site is tied up. And then we start the eye drops again. We go through one, and we hope that one is enough, and then you might have to add a second one, and then hopefully you don't reach 4, and you won't need another surgery, because then you have honeymoon again for 1.5 years, 2 years, whatever it is. Then you have 2 sites down, and what do you do next? You might have to go and do a tube next, or something like that. Or how many sites do you have, especially if it's a young patient? But I have to agree, sometimes we just have to bite the bullet and do the surgery, and then hope that the effect lasts for as long as possible. Yeah.
So just wondering, because things that I've also seen 1 or 2 cases where after the tube was done, I became very quiet. But so I'm just wondering, have you done like SLT or even mix for any of these cases and had a good outcome? I mean, say patients who had on a single agent with cataract, uveitis, and you did an SLT or mix. Do you think that helps?
Single agent glaucoma?
Yeah.
And he's been quiet for a long, long time?
Say has recurrent flares. I mean, but have you done any mix for any of these patients?
No, I have not yet, because it is not advised. There's going to be foreign material in the eye. I have a patient who has been considering for almost 2 years now whether he should have something done for his glaucoma. When he first started to see me, he's already got glaucomatous damage to his nerve, but he's been quiet. So it's 3 years or more than 3 years he's been quiet. The other eye, he had a trabeculectomy because mix wasn't available yet in Singapore. And this other eye, he's on 4 drops, he's complaining of redness, allergy on the eyelids, but he still cannot make a decision. He's very indecisive, very nervous kind of guy. Every time he wants to make a decision about treatment, he's got to talk to his sister, that kind of thing. Yeah. So if I do mix, he would be my first uveitic glaucoma patient, but he's been quiet for many, many years. He's already pseudophakic. He's already had that done. I have not done SLT because it's just not part of the recommendation. And SLT does trigger inflammation in the eye.
I just want to comment that actually, like you say about the trap and tube, they actually do very well. I have that same experience, and sometimes even they were young, they go for the tubes early, much earlier. Sometimes if I can get the eye quite white, they will do the trap, and if you control it very nicely after that, then it actually does very well. I have the same experience, and I do agree that I think it's just the release of all the cytokines away from the,
They're not stuck in there.
Yeah.
They're not
So
stuck
I
in
have
there.
that same experience. Be it tube, I leave it to the glaucoma, whichever they're more comfortable with. Some are more comfortable with tube, that
Yeah.
they do well. But the main thing is to always speak to your glaucoma doctors, I find, after the surgery. Because that's when you need to, they may want to taper it routinely, or the fellows taper routinely thinking it's a routine. And this is when you need to really put your input and say, please don't do this kind of thing. Let me handle, this is the time where I do step in and say, let me handle the post-op.
Yeah.
And with the glaucoma, I said, thank you very much for the surgery, and this, I'll take over for a change.
Yeah.
Yeah.
I think even if it's not a uveitic glaucoma kind of patient, my steroid taper goes over 6 to 9 months. When I was a registrar and when I was in fellowship, some of my seniors would tell me, 3 months after the glaucoma surgery, forget it, stop the steroids. And then they come back in the 4th month and the eye pressure was back where they were before. And the eye is as red as anything because the eye is inflamed again and the trap is essentially failing within 4 months. I think that's terrible. So if you drag it out to about 6 months or 9 months, and the final bit, it could be a once a day Pred Fort, it could be an EOD every other day Pred Fort. It just makes so much difference. Just that little bit longer, you could help the trap survive for years after that. And I have some patients who are now maybe nearly 10 years post-trabeculectomy where I've done this kind of thing and the traps are still surviving without glaucoma eye drops. So even more so, uveitic patient, it would require a much slower taper. You start very intensive every 2 hours. It may go on like that for 1 or 2 months, but the taper needs to have a very, very, very long tail. Very long tail.
Then
Yes.
a couple of one thing is like Ozurdex is picking up, or any of the intravitreal steroids and all. Any word of caution from your glaucoma point of view when we as uveitic specialists are planning for any of those things, and what should we be watching for, and should we be giving or not, and what kind of word of caution for? A lot of people they give, and I'm sure a lot of these practitioners may give.
Yeah.
What do you suggest?
I am really nervous about sustained delivery, steroid implants and that kind of thing.
Yeah.
Because once it's gone in, you can't withhold it. You can't. I mean, you're not going to open up the eye to pluck it out or something like that. Whereas an eye drop steroid can be withheld. You can change the frequency and that kind of thing. You could stop it. You could change to something which is less IOP. Provocative kind of a medication. So I would say if that kind of thing is implanted, do evaluate for glaucoma before that so that you can follow up subsequently. I know it's tough because in a uveitis patient there's so much vitritis or whatever it is, the visual field is not the best kind of visual field. The optic disc photograph is often hazy and we're trying to make guesses where the RNFL rim is and things like that. But if the IOP is high already, it's probably going to get high, be higher, come down and then go up or something like that. It may have all these peaks and troughs, but you know that it can eventually cause more and more and more damage. So let the patient know first that it's not going to be an easy road in terms of the glaucoma medications. They shouldn't drop the glaucoma medications on their own. They should return for a visit with you or with a glaucoma person. And I think remember to periodically do glaucoma tests as well, so that we can track how the things are getting on, how the nerve function and so on is getting on.
Yeah, one more thing which I learned through my practice, and my first intravitreal ganciclovir injection in Singapore eventually immediately became no light person because it was a uveitic glaucoma. And so again, what do you suggest in patients having a uveitic glaucoma? And right now I am having such a patient where I have to give intravitreal ganciclovir.
Yes.
And every third or fourth injection, every time you give and you check that light perception for them, it becomes completely blind. And now I'm prophylactically doing AC tap for that. Maybe what do you suggest where intravitreal injection for any kind of thing is required in a patient with a uveitic glaucoma?
Yeah. So of course AC tap is one way to do it, but AC, well, you're already injecting in the eye. Okay, so AC tap is probably not going to be a lot more invasive than intravitreal. But one other way to do it is one tablet of Dimox. That helps to blunt off any eye pressure rise. The Dimox, you wouldn't want to give too early because the eye becomes too soft, but you don't want to give it after the peak has come, because then you're chasing it. You know, it takes at least half an hour, 1 hour or something like that in order to kick in. So maybe it requires a bit of coordination so that you don't give it too early but you don't give it too late. Because if you've given the jab, you give the patient a prescription, he has to take a walk to the pharmacy, it's a long wait at the pharmacy. By the time he gets the medicine, he could have a CRAO already. I don't know. Yeah, so if there could be some kind of coordination, maybe have the pills at near the injection station, so you jab it and you get them to take it, something like that. Or just before they receive the jab, they receive the Dimox.
I think that's perfect, and I think you will not get this kind of opportunity to interact with the expert and any of the even glaucoma society conferences and any of those things. This is a real feast for all the people and this small little crowd. I think we do not get. Thanks again, Daniel, for spending time. Thank you. You traveled a long distance, right, from the Camden. It was a long walk. Okay, so we'll get we get the course director, Dr. Adrian, will be speaking